really feeling like we have this covered is a little bit more elusive. So currently, in general, the response rates for depression are about 60 to 70%, which you could say, get cup half full, cup half empty. That's pretty good. But we're not getting everybody, and we're not treatment resistant and don't respond. And I think probably even more discouraging than that is the fact that there's a high relapse rate. Now we know that depression, by the nature of what it is, its phenomenology, is it tends to be an episodic problem. So people who can have a significant period of depression, many people really normalize, really get back to close to full level of function. And then if they're faced with a lot of stressors, or if they're in a difficult situation again, can kind of go back down below that line of normal functioning and have another episode of depression. We would like to think, though, that we are developing treatment strategies that teach people some coping skills and some ongoing strategies to help them manage their mood that they can then get back on board as they feel themselves going down, so we could minimize this relapse. And I think we're still kind of struggling with that. You're probably aware there's been a lot of controversy in terms of pharmacological options for treating kids and adolescents. And in the early 1990s, there was a huge increase in putting kids on the selective serotonin reuptake inhibitors, the SSRIs, Prozac Nation, if anybody ever read that book. There's a lot of Prozac going on. And that was, people were very enthusiastic about that, particularly people in primary care settings. And the main reason that they were enthusiastic about it is that there were very few side effects, so it was a very easy medication to use without much risk. And there was very little risk for overdose, which is one of the big things that you're concerned about if you're giving medication to a depressed adolescent. But there's been a lot of limitations to that. One limitation is that there are a lot of kids who are non-responders, about 40% don't respond. About up to 60% of kids have a negative bias about medication, don't want to take it. Really, and I have heard this, and I'm sure that you guys in your own work might hear this, medicine might change me, change my personality, control my thoughts. I don't want to have the thoughts controlled. Yeah?
Is that percentage is just specific to adolescents and their attitude about meds? Or
This is all adolescents,
okay,
yeah. Gray study is of adolescents. And then there's issues about beliefs about efficacy and beliefs about stigma. So you can put a kid on a medication, and they have all sorts of beliefs about what else it's doing in addition to or other than managing their depressive symptoms. Those are all things that need to be discussed and considered. And then there was a big concern about the potential increase in suicide risk in youth using antidepressant medication. And I think we had kind of in the field a dramatic increase in use of medications, and the suicide risk literature came out, and there was a marked decrease. And I think we're now kind of getting to an even ground, even keel about when you would recommend a child consider both a medication and a psychotherapeutic intervention. And that is currently, I would say, the guideline to consider both in a child who has a persistent, significant depression. This is one of the reasons that we are cautious, or you need to be cautious about if you're thinking about referring a child for an antidepressant medication and not a partnered psychotherapeutic intervention, is that some of the research that we've done here, looking at large databases, would suggest that the vast majority of kids just take themselves off their medication, and they take themselves off by about 6 months. And they take themselves off for all the reasons that they aren't very good about taking in the first place. They take themselves off because they've had a good day and they don't think they need it anymore, because they think they're going to gain weight on it, because it interferes with their sexual function, because they're self-conscious taking it, having it with them when they go on an overnight with their church group or their youth group, so they just leave it at home and then they're off of it and they don't take it again. So if we talk about treatment, we thought we were in pretty good shape in 1998, talked about psychotherapeutic treatments. There were some meta-analysis that looked at initial trials of cognitive 1999, there was a larger trial, again, really good effect sizes, so anything above 1 would be a really great effect size. We'd all be really happy with that. And then a slightly larger trial in 2002, and the effect size went down, but I think we would still be pretty happy with that. And then John Weiss and Kerry McCarty, who's here in the Department of Pediatrics, did a large 35 trial study, including the treatment for adolescent depression study, which is the largest multi-site treatment study that's been done in the United States. And they found the effect size that was 0.34, which isn't something that we would be all that enthusiastic about in a large treatment outcome study. And that kind of raised the question of how effective is cognitive behavioral therapy if we're really looking at it as a treatment for depressed adolescents. Now this is an interesting thing where those initial data that I just reported on and the not so positive results about cognitive behavioral therapy were taken in about 12 weeks when cognitive behavioral therapy didn't look as good as medication or medication combined with cognitive behavioral therapy. But if you follow kids out to 36 weeks, this is the TAD study, and all the kids that were on active treatment, they also had a placebo group, but they aren't included on this slide. You see that all the treatments get to a pretty even keel, and all are effective in reducing depression. So I think the take-home message is that not cognitive behavioral therapy didn't necessarily, not that it didn't work, but that it maybe took longer to kick in or affect change. And we as a society aren't very tolerant with time to affect change, so that's an issue. So just moving on to treatment, the two treatments that have the most data in support, that meta-analysis that John Weiss did included both of them, cognitive behavioral therapy and interpersonal psychotherapy are the two treatments with the most evidence in support of work with children, cognitive behavioral therapy. Most of the work on interpersonal psychotherapy has been done with adolescents and is now kind of being tested out with younger people. So the core strategies for cognitive behavioral therapy, and this is what you would be looking for if you were referring somebody to a therapist. Are they talking about these strategies? Are they working in this way? Facilitative, both have that, and that's, do they make a relationship? Obviously central. Behavior activation, which is structuring some pleasant events, getting kids engaged in some more pleasant events, which tend to drop off if you're depressed, if you stop doing some of the things that you like to do. Remember, anhedonia is stepping out of the activities that you like. And then a lot of